Hello everyone, chapter 49, I almost said 50. We're talking about the liver. Okay, so again, I can't stress enough to make sure you know the basic functions of the liver and the pancreas. Remember to go over chapter 43 if necessary, but make sure, there's a lot of functions we don't realize the liver and pancreas do. They do more than just support our GI system. This is a filter. It stores it stores carbs, proteins for us for energy. It filters through what we need and don't need. It gets rid of our waste. It gets rid of old red blood cells, helps process new, many different functions. So it will affect the whole body. It's very complex. So again, another good picture here to remind you, and please go over it. You're going to struggle in, again, make sure you understand the basic patho of it. All right, so here's the metabolic functions right here as stated. It controls, metabolizes glucose, ammonia, protein, fat, vitamin, iron, bile formation, bile, drug. I mean, everything we put in our body gets filtered through there. It's really the dumping station for everything that we do bad. All right, here's your liver function studies. Your AST, your ALT are probably one of the biggest here. Here's all the different kind of studies that you would need to pay attention to with somebody, especially to either rule out liver function issues or somebody who has it. These are the areas you want to look at. Please refer to table 29. Clotting factors is a big one as well. Okay. So ALT and AST, I said, is kind of those real common go-to to see if somebody is having issues or current stature in somebody who has a history of liver problems. So ALT increases primarily in liver disorders, used to monitor the course of hepatitis, cirrhosis, and the effects of treatment that may be toxic to the liver. AST, not specific to liver disease. However, the levels of AST can be increased by cirrhosis, hepatitis, or liver cancer. So it's a good gauge in how somebody's doing, especially with liver disease. Here's some other diagnostic studies. Remember, we always do least invasive first, so that'd be the labs. Liver biopsy to determine causes, prognosis of cancer, other different issues, status of the liver as a whole, sonography, CT, MRI. Again, refer to these tables. They have the big issue of nursing our role and good explanations. Those tables are everything in this book. So dysfunction, remember, acute is onset, chronic, remember that golden number is usually about 6 months. If this continues to be an issue, it's now considered chronic. Cirrhosis of the liver can be caused by many different things, so please make sure you understand that going into a patient's room that has cirrhosis, many things can cause it, but the facade is what? Drinking, alcohol. It's the most common. It's the most, does the most damage over time. However, diet is now huge. We see a lot of non-alcoholic fatty liver disease over the course of years now because of our poor diets, obesity. We are seeing children as young as 7, 10 come back with elevated liver enzymes because they're already starting to show signs of fatty liver disease. So consider that, 10 years old, and they're already showing dysfunction of liver. That's very disheartening and sad. A lot of education needs to go into that. A lot of change, but that's changing a whole society, isn't it? So I've noticed over the course of the years, though, taking care of somebody with cirrhosis or any kind of liver issues, they can be a little sensitive. So understand there's a lot of psychosocial that goes involved in taking care of this population. It's very disheartening and sad that right away somebody has to walk in, or the patient has to right away say, I am not an alcoholic, I don't drink, I don't have that type of cirrhosis, I don't have that type of hepatitis, or whatever the case may be. But we should be walking into their rooms with an open mind and objective and not judging at all, because our role is to advocate and care for them. So just something for thought there. There's a lot of psychosocial that goes into caring for these patients. Okay. Liver failure is associated with alcohol use. Again, it's the most common. And it can be caused by infection or virus. So manifestations. So here are the big issues concerning liver disease. Jaundice. Remember, jaundice is that yellow pigmentation in our skin. It is the ammonia, the bile, everything backed up. Remember, if that filter, that liver, which is a filtration system, is not working, we are going to start to see the backup of our waste all over our body. It is yellow pigment in the eyes, the membranes, the skin. You'll start to have a pruritus that's very itchy because it's trying to come out. one of the nursing interventions you'll see in the tables when you're studying is to make sure their fingernails are short and cut so they don't cut their skin open when they're scratching. So skin integrity. So portal hypertension is just what it sounds like. Don't let it fool you. You know hypertension. So you know that the liver has a lot of bleeding, red blood cells. I'm going over my own words. Sorry. It gets the old red blood cells, turns it into waste, filters, stores blood cells. It's a huge factor there. So what happens is if we have a lot of pressure, if that liver, that filtration system, that system that stores, filters, it's like a big manufacturing system. It starts to be full of fat from a fatty liver. So it's clogged. It's like an artery. It's not going to go through. Okay? If it's cirrhosis, which cirrhosis looks like dry pieces of leather, those sections of the liver are not working. So we're trying to go around it and filter it, and nothing's going through. We can't get the old red blood cells out. We can't get the bili. We can't get the ammonia. We can't get anything out. So it starts to back up and overflow, which is essentially we get jaundice. So essentially these portals, those vessels, those veins start to what? Get bigger and swollen and bigger. And what's going to happen? They will burst. They will burst. And what will happen now is what? A massive GI bleed. This is considered an emergency. It is life-threatening. We bleed out fast. We will go into hypovolemic shock. This is an issue. Okay? Ascites. Ascites is that what we call a beer belly. All that waste, again, is trying to get out. All that ammonia, so it'll start to store wherever it can go. Swelling. It'll start to store in that belly. It causes a lot of distension, pain, massive weight gain, fluid and electrolyte imbalance. Remember, any kind of fluid function will affect your fluid and electrolytes. Hepatic encephalopathy, again, it is not going anywhere. The ammonia, the everything. So where's it going to go? It's going to start to go anywhere. It goes into our brain. Our brain is not a forgiving area. There's no room for swelling. There's no room for anything. If that toxic waste goes to our brain, one of the most common side effects is confusion, altered level of conscious, delusions. One of the weakest parts in healthcare is, or facade, I don't know if that's a way of putting it, is healthcare providers tend to say, oh, that's just how they get, they're confused. They do that every night. They just kind of bypass it. And it is, I can't stress it enough, it is never okay to be confused. It is never normal to be delirious. It is never normal to be confused. I don't care what the age is, that is a sign and symptom of something's wrong. We, as healthcare providers, should not take that lightly. It is a key part of our assessment. We need to really look into the cause of this and not just blow it off. And it can be an early sign of something. We want to be the nurses that find symptoms early. And nutritional deficits for many reasons. The fullness of, the waste, a lot of GI disorders, and going into psychosocial. If it's an alcohol drug disorder, they would rather save room for the alcohol than the food. The food absorbs the alcohol. They tend to get sober. That's no fun for them. So there's many issues. And also the filtration. Remember, the protein, the carbs, it's a vital area of where all that gets filtered. So please remember that. Okay, kind of went over this a little bit already in that last slide. I tend to do that. So remember the coloring issue, the color, the yellow, the greenish. There's your belly level right there. Shouldn't be any higher than 2. Okay. So signs. So the biggest issue when it comes to liver disorders, a viral cirrhosis of any kind, patients complain of constant chronic fatigue. Immensely, they do. It is horrible. It is a lot of malice, a lot of fatigue. They just can't get up. They just can't do anything. That's one of the biggest signs. And how vague is that? It could be many things. Weakness, headache, chills, fever, lack of appetite, as stated over there, nausea, vomiting, weight loss. They're not getting anything in. They're not metabolizing anything. Obstructive. If it starts to be obstructive, we'll start seeing that dark orange urine, that clay-colored stool. There's no bile in there. Dyspepsia, intolerance of fat, impaired digestion, pruritus, that itchy. So portal hypertension, as I kind of stated, obstruction of flow from the liver results in increased pressure through those portal veins. One of the biggest interventions here, remember, is beta blockers. So remember, hypertension is essentially the same everywhere. So just you got to remember that. This is why it's so important to know the pharmacokinetics of our medications. It can result in ascites and esophageal varices. They're getting thin and they're getting weak. They're getting really pressured. So let's talk about ascites and how uncomfortable it is. So you have a big ball of fluid here. That can cause a lot of anxiety, shortness of breath. There's no room, discomfort. Exercising is hard. Movement, just walking, decreased stamina. Changes in ability to metabolize aldosterone. So you're going to have that fluid shift. You're going to have that fluid and electrolyte shift. So as I'm saying these to you, you as the nurse, this is how you study. You say, okay, if that fluid shift is going to happen, what should I do? What should I monitor? I'm going to start monitoring that CBC. I'm going to start monitoring that BMP, those labs. We're going to have to probably start replacing. We're going to probably have to start giving diuretics. But remember, there's a cause and effect. And you have to always reevaluate your patient to make sure that what you're doing is correct. And so we're going to give those diuretics. We're going to get some of that fluid off. But what's going to happen now? We are diuresing those electrolytes. We have to replace. It's a constant cycle. These things are not a cure. It is interventions to support them till we can find the cause, till we can treat the cause. Okay? So it's movement of albumin to the peritoneal cavities. Please pay attention to figure 49.5. It'll help you kind of put the pieces together. All right? So again, crucial data you need, right? Daily weights. If they're going to go get a paracentesis, which is a puncture in the abdomen to take out some of that waste and that fluid for comfort. This isn't a cure. This is just to support the patient and help them feel better. We have to take vitals before and after. We have to make sure we record abdominal girth. Constant daily weights. Remember the same story every time. Same time every day, before and after procedure. Checking swelling always. You'll tend to see those veins that are being stretched in somebody who has alcoholism, those thick little spider veins here that you start to see stretched. You'll start seeing those veins stretched out in the tummy because that skin is stretched. Monopotential fluid and electrolyte imbalance. Okay, went over that. Here's just assessing for fluid. That's the picture from your book. So treatment, low sodium diet. Why? It's attracted. Diuretics, as stated prior right now. Again, huge intervention, constant monitoring of labs, constant monitor of replacement. This is all day long. Bed rest for that fatigue. That's all we can do. Making sure they're sitting up properly. They're going to have some anxiety for feeling short of breath. Making sure comfort measures are happening. That paracentesis is done in radiology. It's a puncture in the tummy, again, to excrete that fluid. Some procedures that we can do to kind of bypass these areas of pressure to start helping to filter these this waste through that we're holding in is TIPS. Here's kind of right here. So we're putting in this filter right here to kind of help filtration through and bypass those veins to reduce the pressure. Okay, understand your role in these surgeries and what happens. Hepatic encephalopathy, I went over it a little bit prior. Remember, this is life-altering. This is life-threatening. Those early mental changes and motor disturbances, they'll start having more of a sluggish gait. We don't indulge in their delusions. We try to gently orient them back, making sure they're safe, decluttering that room. Don't always go into interventions that it's a medication. Go into what you can do in your role. We do administer medications, correct, but we cannot order medications. So what is your nursing role? There's so many things we can do prior. Let's keep them safe while we're getting that order. Let's declutter that room. If we have to, let's, turn the bed a different way to reorient them. Let's get that sitter. Let's have a family member possibly be with them, somebody that's familiar. Okay, but this is life-altering. It's life-threatening. The only thing that's going to support this is removing the waste. Lactulose is one of the biggest medications that we use for this. Lactulose is working by, it stimulates bowel movement, but it also is pulling that ammonia, that waste, everything that we can't get rid of that's trying to come out of our pores and going to our head out into poop. So what is the effect of lactulose? To poop. Is it used for constipation? No. Students get this confused all the time. If I'm constipated right now, I am not going to choose lactulose. I do not need my waste to go anywhere. Okay? I'm going to choose a different laxative. Lactulose is to pull that waste out through the route of stool. Okay, so some of the assessments here and findings to rule in or rule out hepatic encephalopathy is an EEG that shows the functions of the brain, the level of conscious. Possible seizures can happen, and unfortunately, this is usually when it gets diagnosed, and that's kind of latent, very life-threatening. Fluid and electrolytes and ammonia is huge here. We have to constantly monitor. We're talking every 2 hours, 4 hours. These patients are in an ICU setting from the minute any of this is diagnosed until we have stable labs, stable patients. Okay, again, very life-altering. Go through the stages in more detail, and it'll give you more nursing interventions. Please know asterixis and apraxia. These are some of the signs and symptoms as well due to the complications. Know the difference. So we have to eliminate the cause. Obviously, we got to stop. We're going to treat the symptoms. We're going to move the waste. But remember, none of this is going to stop until we treat and find that cause. Possible glucose issues because of the blockage and because of the non-functioning liver. Remember, it filters our protein and carbohydrates, so we're going to have to decrease that. Anything that the liver filtered through, we have to decrease. Alcohol. Remember, think of medications that are so hepatic toxic. So we have to actually see, we have to address, does this patient really need this medication? Because it's not going to metabolize through. If we give an opiate, it's not going to metabolize through. This patient can go into respiratory distress because they just can't metabolize it through. They can't get through the system. Okay, so everything has to be taken into consideration. We give everything in mild form. And again, cause and effect. We're putting Band-Aids on. If they needed that blood pressure medication or a cardiac medication, is it necessary to give it right now? Is this life-threatening to the patient? It's a lot of Band-Aids. Is this going to cause more harm than good? A lot of the time I've seen that they'll still give these medications, but they'll give it in smaller doses. But what's the problem with that? We're going to see blood pressures go up, cholesterol go up, So it becomes this snowball effect of issues. So again, please remember, just like the diuretics, everything we do has a cause, and we can't just say, no, I can't give it to you anymore. We have to eliminate and see what the patient really needs. Let's see, discontinue sedatives, or we're giving it in mild form, very mild form. Reduction of ammonia and gastric secretions through enemas and antibiotics, and treat for complications and infections. Remember, it's bile and waste going through our body. This is a very high-risk patient for going into sepsis and shock because of the toxins going through our body. So that can be another big issue here. Okay, esophageal varices. Okay, those are those stretched, pressured blood vessels, right? Occurs in 1/3 of patients with cirrhosis. Remember that filter, so they're getting backed up, they're getting stretched out. First bleeding episode has a mortality of 10% to 30%. This is a massive GI bleed. This is an emergency. This patient will die. One of the first signs and symptoms, the manifestations is hematemesis, which is bloody vomit. If they see that, they need to call 911. They need to get to an ER right away. If they are already in the hospital, we need to get them to a higher acuity of care, such as an ICU. Remember, they are bleeding internally. It may be a latent sign of low blood pressure, high heart rate, right? If we are losing volume, and we're losing volume that fast, what is our role? To start replacing as fast as we can. It is not going to fix anything, but it buys them time to find the problem, find the bleed. So we are giving either massive amounts of fluid, massive amounts of blood, and don't remember there's many components to the blood that we are going to start to dilute out if we keep giving. We're talking plasma, platelets. So what as nurses are we going to do? We're going to make sure we advocate and get this for them. Those I's and O's. This is a life-altering situation. It is an emergency. We are monitoring those labs to see, is there any improvement? Is there not? What do we need to replace now? Where do we go from here? Okay, patients with cirrhosis should undergo screening of an endoscopy every 2 to 3 years to prevent this. And if we find these variances, we can eradicate them in a way that we can prevent a GI bleed. Again, that they can bleed out in minutes. Here is the physiologic and patho of them for you to review. So treatment, again, it's always least invasive, but here we go. What kind of shock? I said it earlier. Shock is shock. Remember the signs and symptoms of that? That is a lecture for another day. But there's different types. This one would be what? They're bleeding, losing volume, hypovolemic shock. Administer oxygen. If we're losing our blood, there's no way of perfusing. There's no route of any of that, okay? So administer oxygen and replace, replace, replace. IV fluids, there you go. Electrolytes, volume expanders, a lot of volume expanders that we use. Okay, I keep talking about giving fluids. I keep talking about giving blood. But the body takes time to metabolize things through and get it where it needs to go. And that's what happens with fluid overload. What happens? We start ballooning up and swelling, because our body takes time to absorb it and put it in the cells where it needs to go. So we use, one, for example, is albumin. Albumin is a protein. It pulls the fluid into the cells where it needs to go. So this could help possibly get the fluid where it needs to. Blood and blood products. Here's the medications. You need to know this. You need to understand why you're giving something. Do not try to remember this. Understand why these medications would be a point here. If we are bleeding, a vasopressin will decrease the bleeding. How? That's how you need to know it. Nitro. Isn't that usually what for the heart? To decrease the pressure? Well, we're decreasing the bleeding here, right? By what? Reducing the constriction. Propranolol, as stated earlier, decreased portal pressure used in combination with other treatments. And a balloon tamponade. So what does the balloon do? We'll put in, it's almost like a cath. It'll go in through the esophagus and it'll find the area of bleed and it'll temporarily put a balloon to obstruct the bleeding. Here are some of the treatments. Most of these are surgical, and remember, when this is diagnosed, it is considered an intensive care patient. They need to stay, it's a protocol to stay so long in the ICU to prevent any more bleeding, volume imbalance, obstruction of airway. There's many things that go into play here. So here's one right here, the sclerotherapy. Haven't had enough coffee, sorry guys. This one right here, as you see, it kind of cauterizes the area of bleed. One of the other ones is the banding. It takes the section of the area where the variance is and kind of not cauterizes it, but tightens it up so it stops. It bands it up. Here's a few other systemic shunts. It's just what it sounds like. It bypasses. It finds the area issue. Here's the different ones. And it bypasses, cauterizes, and moves it another way around. It reroutes. Okay? So part of our management for this is depending on the surgery, depending on the issue, depending on the cause. But one thing is for sure, they are volume lost. This is critical. So every patient's going to have a different management, but these are your main ones here. Maintaining that safe environment for confusion, for safety. If they're at risk for bleeding, are we going to want them bumping into their tables? Are we going to want them hitting themselves? We want to probably pad the bed rails. Different things like that. Keeping the room in a safe environment. Giving those medications when necessary. Making sure that these medications are going to be available to them. Monitor for complications. Assessments, constant assessments in this critical area is key. Any subtle change, the sooner we report a subtle change is the better outcome for our patient. And by knowing that subtle change is by getting to know that patient, knowing how they were when you received them, how they've been through the course of your day. They haven't been doing that. That's not right for that patient. You learn that through time and taking the time to do so. Encourage deep breathing positions. Again, a lot of this is painful. A lot of this is discomfort. Let's consider ascites with the big belly. Sit them up. They should probably never be lying down. Reposition, shifting the hips if they can't completely turn. Use those pillows. Educate and support the family. Understand prevention is long gone now, but what can we do from here? Educate and advocate for them. Okay? Skin integrity is big. Remember that.